Okay, we'll start. So welcome to our 8th webinar in Nutrition Nuggets educational series and entitled Nutrition in Pediatric Cancer, Enteral or Parental. And I hand over to the speakers who will introduce themselves. Enjoy.
Thank you. Good afternoon, everyone. My name is Isla, and I'm one of the specialist pediatric dietitians at Great Ormond Street within the hematology and oncology specialty.
And hi, I'm Julie. I am also one of the specialist pediatric hematology and oncology dietitians at Great Ormond Street.
So we're just going to share our screen. We will get started. Perfect. Can you all see that? Perfect. Yes. Thank you. So as Mary said, thank you guys for all coming. And so what we're going to talk about today is nutrition in pediatric cancer, focusing on enteral or parental nutrition. So as a bit of an overview, we're just going to talk about obviously enteral nutrition and parental nutrition. So firstly, what is it? When would we choose it? And also when we may consider kind of early nasogastric or gastrostomy considerations. And with parenteral nutrition, very similarly, we'll say what is PN, appropriate indications for PN, how's it delivered, and when do we look at weaning. So just as a broad definition, I know most of you probably are aware of what enteral nutrition is, but it is defined as the delivery of nutrients through an enteral route or via a feeding tube. So typically this is considered when a child is not able to meet nutrition requirements orally. So there's multiple different ways that we can, put in feeding tubes. They either go through the nose, the mouth, the stomach, or the small intestine. And they are used as a means to deliver feeds or nutrients or fluids, medications as well, into the stomach or small intestine. Generally, enteral nutrition is kind of used prior to parenteral nutrition, and if the gastrointestinal tract is able to be used, it is preferable to use it. So what do we know about enteral tube feeding? So we know that it improves nutritional status during intensive treatment with minimal complications. It is also associated with lower incidence of infections compared to parenteral nutrition and can maintain and restore the gut integrity, which we will touch on a little bit later. Now, within many centres, we are starting to see, it is well known that, early intervention with enteral tube feeding is beneficial to help prevent nutritional decline during treatment. We know that our patients that are kept well nourished and maintain their nutrition status throughout treatment have, lower risk of, developing associated toxicities, longer inpatient stays, as well as, we don't see that weight loss as well as treatment dosage adjustments. It is beneficial to prophylactically consider nasogastric tube placement in high-risk diagnosis, which we'll touch on in a second. It's also considered, where we may expect side effects such as mucositis, bleeding risks, and we also know that it can be shown to reduce parental anxiety, and it's additionally useful for medications and fluids. Touching a little bit on parental anxiety. So we do know that, our patients that do go through these treatments are often in and out of hospital a lot. There's a lot of disruptions to kind of the general, food environment, as well as kind of, the familiarity of foods, and able to maintain nutrition and eating and drinking as also kind of a source of, pleasure, as well as kind of keeping with, they're helping, prevent that parental anxiety around, keeping their child well nourished. And also it's really important to collaborate with a multidisciplinary team, manage expectations, consider whether or not it's appropriate for the child, and there's social situation, as well as diagnosis, prognosis, type of treatment, and whereabouts they are in treatment as well. So just a couple of diagnoses where we would consider early nasogastric tube or gastrostomy interventions. So we know that diagnoses that require treatment on intensive treatment protocols, or ones where we are more likely to see treatment-associated side effects such as mucositis, or those that are placed on high emetogenic treatments, do benefit from early nasogastric tube insertion. So, for example, that can include, in the hematology ones, things like acute myeloid leukemia, Burkitt's lymphoma, infant ALL. With gastrostomy considerations, it obviously is, patient dependent. With our hematology diagnosis, such as acute myeloid leukemia, if they are, going on for bone marrow transplant, it is really important to consider that and get that talking, with the teams as early as possible, so that that can be fit in when they are count recovered. There may obviously be situations where that isn't appropriate. For example, in our really high risk acute myeloid leukemias, we can see that it is too high risk to allow them to count recover and go for surgery. So that's again where we just need to kind of weigh up the cost benefits of that. In our solid tumours, you can see here a lot of them do require early nasogastric tube considerations. Some of them are not able to be considered for gastrostomy placements just due to the location of their solid tumours. So we know that in the high-risk neuroblastoma category, even though they have got a really high intensity of treatment and are very prone to and are put on chemotherapy that is very highly emetogenic, that it isn't always possible to pop that in place because of where their tumor is located. Very high risk rhabdomyosarcomas as well, especially prior to proton beam therapy, if not earlier. And also in our neuro-onc population, as you can see, gastrostomy is just because of the location of the tumor, as well as we know that they often do go on to need it throughout radiotherapy. So other reasons to consider gastrostomy. So I guess it is important to remember that this is a case-by-case basis, and again, important collaboration with your multidisciplinary teams, your families, as well as your other medical professionals is needed. So for example, other cases where we may consider gastrostomies, where we typically may not consider the ones that are requiring long-term nutritional support, unable to tolerate a nasogastric tube. So typically in the older patients, we are frequently seeing that they are, not liking, kind of how it is when they needing to go to school with the nasogastric tube. So talking with your teams about that early on, as well as nasopharyngeal tumors, with the location of where the tumor is. It might not be appropriate to insert things like a nasogastric tube, so getting those talks in early as well. So now on to parenteral nutrition. So what is parenteral nutrition? So this is nutrition that is infused directly into the bloodstream by bypassing the gastrointestinal tract. So it's where nutrition is broken down into its simplest form. So things such as the carbohydrates broken down to glucose, fat into lipids, protein into your amino acids, and as well as adding in your electrolytes and your macronutrients. So the preferred way of administering PN is via central venous access line. So this allows for the use of more concentrated solutions and can maximize a patient's nutritional intake, particularly when they are fluid restricted, or when we are needing to kind of tailor their nutrition volumes due to drug volumes, blood and platelet transfusions.
With parenteral nutrition, it's just about thinking about when it's indicated, and this is where you have to make sure it's appropriate, and we're not just putting. I tend to find on our hematology and oncology wards, because a lot of our children, if not all, have central lines, I think we sometimes use parenteral nutrition more readily than it is appropriate or indicated. I mean, we should be really thinking about only using it when it's absolutely necessary. So when we cannot use enteral nutrition to prevent or reverse malnutrition would be a scenario. We have to remember that PN is actually quite hazardous and expensive, and we need to consider these indications. But more importantly, it's typically only built up over 2 to 4 days. So sometimes, we've got children that maybe have become neutropenic, they've got mucositis, but actually they're towards the end of that period. So maybe we haven't had optimal enteral feeding, but then they'll say, oh, they haven't eaten in X amount of time, we need to put them on PN. But actually we're expecting them to count recover in the next 2 days, and they may very well start eating, and the medical team might anticipate that they'd be fine within 4 or 5 days. So you have to think, well, if we're going to take 2 to 4 days to build up to optimal nutrition with PN, we're accessing the central line more than we need to. We're, putting additional stresses on the body to not even achieve optimal nutrition in that 4 to 5 day period, and that by which point we're expecting them to eat or tolerate enteral feeds better. And I often like to think, if they didn't have a central line, would we be going to PN quite so quickly? And I don't think on the other wards we do. So that's kind of why in our protocols at GOSH, we say PN is not indicated if we expect it to be used for less than 5 days, because we're not adding much nutritional value if we're going to stop it before then, because we're still building it up. So this is just a kind of the guide that we tend to use, and I find I'm often, this is where the NDT communication is key in those ward rounds, where, obviously I'm not a doctor, and there are exceptions and unique scenarios within these guidelines where I might think it's not indicated, but the doctors are able to explain to me in the scenario why it is. But similarly, we deal with PN and indications for PN quite frequently, and it's just helping remind them if it truly is indicated or not. So what you'll see here is you would consider PN if enteral tube feeding is contraindicated or there's gut dysfunction for more than 5 days. So if it's post-bowel surgery, intestinal obstruction, ileus, severe mucositis or enteritis, diffuse peritonitis, intestinal perforation, active GI bleeds or gut ischemia, severe shock, or neutropenic enterocolitis. So obviously it's not everything on the list, but that gives you a good idea of when we would be thinking about PN. And one of my pet arguments I have with the team, collaborative discussions, is about pancreatitis, because actually PN isn't indicated in pancreatitis. The evidence at this time often says, unless they're symptomatic, you don't even need to alter the fat in their diet. And then only when they're symptomatic, you might be thinking about low-fat diets. But even then, there's limited evidence. But PN is certainly not it, and certainly not lipid-free PN, where you're giving them minimal calories. But there was a perfect example. We've had a patient which had a really extreme response, and actually it was entirely appropriate that they did have PN. So there are always exceptions to the rule, and that's why, entity collaboration is so key. On the other side, in terms of thinking about indications for PN, and I think this is actually where this grey area comes in, is enteral tube and oral feeding when it's less than 50% of energy requirements for 3 to 5 days, or we're not able to advance the feeds. And that might be due to feed intolerance, mucositis, diarrhea, vomiting, GVHD. And I think the difficulty here is, obviously in our acute patients, that picture is always fluctuating and changing. So, what you can find yourself trapped in is a bit of, oh, but they might get, we're expecting this issue to resolve, or they've just spiked once they get over the fever, let's not start PN just yet. And then actually, before you know it, it's actually been 2 weeks and we've not fed the child. Then we start PN, and then actually they do get over 1 or 2 things, and then we think, oh God, we didn't need to start it. And I think in those situations, it's just about, really critically breaking down the clinical picture you have. Why are they vomiting? What is their diarrhea? Have they got virus in their stools, and we're expecting that they'll have continued diarrhea for a while, and that isn't expected to resolve? Is it feed intolerance? What's causing that intolerance? Have we optimized their antiemetics? Could we be changing their feed? So I think we need to make sure that we've exhausted all appropriate options enterally first, but that if the clinical picture really is kind of one thing's piling on top of another, and we're really starting to see the compromise of their child's nutritional status, then it might say even if they do get better, they really need this PN for a while to get on top of things before we can get a simpler clinical picture and then start to push enterally. So that certainly isn't black and white, and that's why, you know, all these team members, the nurses looking after the patients, the doctors, the dietitians, the PN pharmacists, the gastroenterologists, that's why that, you know, working together is so key. But like we've mentioned, I think what we often hear is sometimes we have a child not eating, their electrolytes are off the wall, and then they say, oh, well, they need PN. But actually, it might be that we could support them with tube feeds, and it's to remember that PN is not used for electrolyte management, and it shouldn't be used if we're only intending it to be needed for 3 to 5 days for the reasons I've mentioned previously. So how is it administered? So you can get continuous and cyclical PN. So continuous would be 24 hours of continuous infusion of both aqueous and lipid bags. What we often find, because it tends to coincide with severe mucositis symptoms or the need for PN, is that a lot of our children might be on a nurse-controlled analgesic or patient-controlled analgesic, and because they need fluids running alongside that, we tend to keep the PN infusion in place of the fluids so that they're not missing out on the PN provision and we're optimizing their nutrition. But it has to be 24 hours because of the pain management. Because we're always asking in PN around, oh, can we do it for less hours? But the minute we see they're on pain management, that tends to be why they stay on a 24-hour infusion. Why would we do cyclical? If they're not on pain management, it's just great to have less hours connected to allow for mobility and any kind of physiotherapy or any other activities. It also allows a break to help better manage insulin and balance glucagon stores, and it can help reduce the risk of liver disease. So we try and support that as soon as we're able. So as soon as our children are stable on PN, if we and they no longer require pain management, we'll go down to 20 hours, 16, 18, well, 18, 16, 12 if they're bigger and we can. Obviously, it depends on the size of the child. If it's an infant, they can't go that long without having nutrition, but hopefully by then we're building up some trophic feeds and they would get enteral nutrition in those breaks. If we have concerns about blood glucose management and hypoglycemia, like I said, particularly with a small infant, if for whatever reason we're not able to build enteral feeds, it might be that we need to consider a wind down, so halving a PN rate for an hour and then halving it again for a half hour and then stopping it to allow the body time to adjust to the reduced glucose provision. So how do we protect the liver with PN? That is the question. So we're big fans of lipids in the PN. So that's just a combination of 4 different types of fats, which is soya, MCT, olive, and fish oils. And it's more liver protective. And we try and introduce lipid-free days as soon as growth is stable. So that tends to be more for our longer term patients, you know, children who are going through an acute period of mucositis might only need PN for 10 days, 2 weeks, 3 weeks. But if we've got children who've got chronic gut issues and they might be on PN for months, we really will be worrying about the function of the liver, and we'd really want to build in some lipid-free days. So it might be that they have alternating lipid-free days or 3 days a week, but that can be really beneficial. So we might cycle the PN in long-term patients, and like I said, eventually you might aim for 12 hours of PN overnight, and then they are fully free in the day. And like I said, we mentioned about titrating, doing wind downs if we're worried about hypos. And wherever possible, we're always trying to support some trophic enteral feeds, if possible, because it is also liver protective. So trophic feeding when on PN. So the aim is to initiate when appropriate. So definitions of trophic feeds can vary, but somewhere between 5 to 10 mils per kilo. I tend to think something's better than nothing. Obviously, if it's like 2 mils twice a day in an 8-year-old, that is nothing. But you know, I wouldn't get too caught up on the 5 or 10 mils per kilo exactly. If we're near there or we've got some volume going in, you just really want enough to stimulate, bile secretions and pancreatic stimulation, and the evidence to suggest how much volume you require. That's where it's a bit sparse, and this is how you land on the 5 to 10 mils. But like I say, something's better than nothing. So It's been shown that intraluminal nutrients are the single most important factors in promoting intestinal adaptation, and the absence of these nutrients is associated with atrophic changes in the gut mucosa. So I think often it seems almost counterintuitive when the gut's going through such a tough time, you tend to think it needs a break. But giving these things, even at a trophic level, is what will help maintain it and help it adapt and help it recover. So provided we're not getting big GI bleeds or things aren't entirely acute and disastrous, we try and support trophic feeds where possible. So like I said, enteral nutrition can preserve the intestinal mucosa, which is important for gut mobility, stimulating, like I said, the hepatobiliary secretions, and reducing the chance of PN-induced cholestasis and bacterial translocation. So that's the other thing we're big on. Everyone's talking about the gut microbiome. I certainly use that word way too much, but it is really beneficial for the gut microbiome, which we'll go on, I think we'll pick up on now. So I think here's a beautiful, healthy picture on the left of broccoli landing in a healthy gut microbiome. But the idea is that we have our own microenvironment in there, and we destroy it in hematology and oncology. Of course, we're doing good things and getting rid of cancer, but actually with the antimicrobials, the other medications, the chemotherapy, the radiotherapy, the GI mucositis, and then, of course, our children are struggling to eat, and it's not uncommon that their diet quality is quite poor. We're really destroying the balance of good, healthy bacteria in the gut. And that can result in, as we said, gut dysbiosis, and that can impair recovery and feed tolerance. So by kind of gently and constantly putting feed in where possible, you're helping feed that good bacteria and you're helping to restore that gut microbiome, which can improve, feed tolerance, it can improve recovery. So that's where the big focus is these days, is we want to acknowledge that imbalance that we've created, and we want to limit the expansion of pathogenic bacteria, and we want to improve the restoration of that good bacteria. So when to start weaning PN? So I think there's no perfect start line. I think it's always a discussion with the medical team, with pharmacy. I think the general idea is we're looking for that engraftment, that count recovery. So once we start to see clinically that things are heading in the right direction, that's when we anticipate symptoms will start to improve. And that's kind of the time where everyone's kind of saying the same thing, which is, oh, should we start some trophic feeds if we've had to stop them? So we'll always start with a small amount of oral or enteral, depending on the age of the child. Some children have always been brilliant eaters, and the minute they start to feel better, they're dying to have a bit of toast or a bit of this. So we can start there. Or if it's a child that's never really had that opportunity and has been quite reliant on tube feeds prior to, it might be that we just start with a trophic NG feed. And then we slowly build up. And it depends how quickly they're progressing. Of course, there are always other complications, whether it's VOD or whether it's other infections or temp spikes. So that might affect the rate at which you progress. If it's a really small, malnourished child, you might want to optimize PN as long as possible and get a bit of that overlap whilst we're building up. If it's a child that's actually quite robust and progressing quite well, you might wean PN more quickly. So it really depends on the individual. And then of course you always need to consider the risks of weaning, like the considerations when weaning PN. So as we mentioned in previous cases, you might need to consider hypoglycemia and electrolyte imbalances. And I think for children who've been quite unstable on PN, that's when you really need to think about how they're tolerating their enteral feeds. So if a child's really struggled with their electrolytes or their blood glucose levels during PN, you would really want to ensure that they may be getting a bit more substantial feed to account for that. Or I'm always very keen to get off PN, so if we know that's the case, we chat with the medical team and we say really keep an eye on those electrolytes and just do corrections and replacements at ward level rather than relying on the PN back, because we don't want them on PN when they don't need to be. And if they weren't on PN at that time and they were having electrolyte imbalances, we wouldn't put them on PN for that reason. So actually we should be looking to correct them in other ways. So that's kind of pros and cons and considerations of enteral feeding versus parental nutrition. I hope you've gathered that we're very pro-enteral for as long as possible. But of course, there is always a time and a place for PN, and that's absolutely fine. But you need to think about very carefully about where, if it's appropriate at all, when it's appropriate, how to optimize it, and how to advocate for getting it, weaning down PN as soon as appropriate. So yeah. So I thought what might be helpful is running through a bit of a case study. This isn't the most complex one, but it's nice to kind of get a bit of a practical example. So I've got a 13-month-old female, and she's got a diagnosis of a high-risk neuroblastoma. For those who aren't too familiar with that exact diagnosis, there's an 18-month multimodal treatment. So she would have had many weeks, some months of regular chemotherapy, and then she would go for, this particular example is her admission for a high dose chemotherapy and autologous stem cell transplant, and then she'll go on to still require surgery, radiotherapy, and immunotherapy. So she's right in the thick of it, where she's at risk of malnutrition and has been since diagnosis, but she's also still got a journey ahead of her. So we really need to work quite hard to optimize her nutrition. So it's kind of how do we balance these things between each other, but also during high dose, because the chemo is quite intensive. We know she's likely to require PM. So it's just about if and when and how you do it. So she has a history of faltering growth and vomiting. So in the months prior, there was a lot of work about we got NG feeds in, there was challenges around compliance and tolerance. So ideally, I would have liked her on the 1 calorie per ml feed, but there were lots of vomiting and tolerance issues associated with that, unfortunately. So where we landed on the submission is she was on a oral bottle feeds of whole protein feed. On a side note, she had high calcium levels, so she needed to move to a low calcium feed, which is not typical, but just you'll see that mentioned later. But the cow's milk protein was whole protein, so it wasn't hydrolyzed or amino acid, and she was feeding okay, but certainly not well enough to support her weight and her nutritional status. So we were trying to work quite hard to support and facilitate appropriate energy top-ups, but also it's that crucial age of weaning, and we want to continue to support and encourage progressing with her solid diet. At 13 months, you could probably imagine she was a bit delayed, so she's having purees, and we're really trying to progress textures and include savory foods and proteins because that increases calories. So what we did, we supported her on her full enteral diet as listed above for as long as we were able. So until 10 days post chemo, which in her case was when the symptoms started to kind of take more hold. Once she developed mucositis, mouth ulcers, abdo pain, that was when the decision was made to transition to PN, and we tried to maximize the calories. We knew she'd need bespoke PN because they often have fluid limitations as well. So we tried to optimize the calories in the PN. And then when it was time to wean her off, so when she was engrafted and recovering, we weaned her back onto the formula that she was on. And because that wasn't going to be appropriate calories once she was on the ideal volume, we built up that formula's concentration. So here's just an example of the timeline. So she started chemo on the 1st of September. Day 0, so she received her cells. So she would have received chemo for those days leading up. She received her and then by day 10, so up to 10 days post her first day of chemo, she started to, she was developing symptoms but still drinking well and tolerating. And then that was the day when we were like, okay, we're taking a turn in that direction of her not tolerating the feeds. She was vomiting, she was developing loose stools, she was in a lot of pain and discomfort. And then once she'd engrafted and the count recovery was heading in the right direction, we started with some trophic feeds. So about 12 days later, and within 7 days, so within a week, we were able to wean down her PN. So to reflect on that timeline, here's just an example of what her feed plan looked like when we were building trophic feeds. So we started at standard concentration because she had difficulty tolerating higher concentration feeds, and we did small bolus feeds, so 10 mils 3 hourly, and we increased by 5 mils each day if she tolerated it. And you can see at that volume, she was fluid restricted at this time. She only really managed to have 53% of her requirements. So we knew once we got there, we were definitely going to have to concentrate the feed further. Hopefully her fluid would be liberalized a bit more. So kind of to the rationale to talk you through how we landed there, I think our general practice is that unless there's a notable insult to gut or gut function, such as GI bleeds or other complications like pancreatitis or tonsillitis, we really try and opt for whole protein and where age appropriate, because obviously infant feeds don't have additional fiber, but fiber feeds, because we know that fiber is food for the good bacteria. And the only real pushback we get on that is what if it makes their stools more loose? But it doesn't tend to, because actually the fiber in the fiber feeds is more soluble, which actually helps with binding stool together. So if anything, it's helpful. But often the children who have loose stools, it's because of their mucositis, it's because of a virus they have in the stool, or they're on lots of antibiotics. I very rarely, with all those symptoms, found a fiber feed has made any negative impact. So we always try and support whole protein fiber feeds where appropriate, because it can support, as we've mentioned, the improvement or restoration of the gut microbiome, which can facilitate gut recovery and improve tolerance. And where appropriate, we'll use bolus style feeding because it's more physiological, and often we're trying to support our children eating alongside where appropriate. So bolus is where appropriate will do. Of course, there are always exceptions, and of course, their children have really difficult times. And if you need continuous feeds, go for it. But we're always putting in feed breaks where we can. And if you have indications and need for hydrolyzed feeds or feeds that have MCT content because the liver function's impaired, then of course we do use those. But I find more and more people use them out of habit rather than actually seeing if it's indicated. And actually, the more you unpick the symptoms, the more you see that actually it's not, the feed tolerance issue is not feed related. It's due to these other things, and more often than not, they can tolerate these whole protein fiber feeds. And then our rationale, so we always advocate to start enteral feeds as soon as possible, and we work closely with the MDT. So weaning PN for this child, why didn't we wean quicker? She developed a complication where she had to be fluid restricted. So we wanted to optimize her calories as best we can for as long as we could. But she also had a poor feed tolerance history in terms of volumes. So that's why we went up slowly. So I didn't want to wean the PN too quickly because I wanted her to get some calories. But because she was fluid restricted, there does come that point of, well, we're either giving feed or we're giving PN. We can't overload her. And I think there's often this misconception that PN will give you more nutrition. But PN can only be concentrated to a maximum of 1 calorie per mil. In her case, as an infant, that's pretty good. But in an older child, you may often go for 1.5 calories per mil, or even 2 calories per mil if they've tolerated it. Not if you're opting to give PN over that, you're giving less calories. So giving PN is not a guarantee that you're providing better nutrition for your child. In this case, she tolerated the buildup of feeds really well. We weaned off PN, and we've since concentrated the feeds now. Her fluid target's been liberalized. She's drinking really well. She's taking solids again. So we're certainly heading in the right direction. In terms of reflections, I suppose, could we have maintained trophic feeds during her period of PN? I think possibly, and maybe that's something I need to be advocating for a bit more. But I think, there is this limit of sometimes when they get to the thick of it, mucositis wise, if feeding is causing them pain and discomfort, do we just let them have that break? And, allow that fluid to be used, especially if they're restricted for PN. And then when she's heading in a bit better direction and when the trophic feeds will be more meaningful for her, can we start it sooner? But, it's always something to think on, and there's always ways to improve and, fine-tune our practice. And then, of course, always consider the impact of fluid restrictions. So our children can always be fluid restricted, and, they'll have blood products, IV antibiotics, other things, and then before you know it, you've not got much fluid left, whether it's for enteral or for PN. Depending on, again, the age of your child, you might actually be able to achieve more with enteral, or maybe it's about saying, well, we're keeping this child on PN and we're not progressing with enteral, but actually they're not even getting their full PN bag because they're getting everything else. So it's about saying, well, if you are giving PN, make sure you're doing it properly and you're not just sending up 500 mils only for 200 to be used. So, these are all our considerations for enteral versus parental. I hope that was helpful. Do let me know if you've got any questions. I stopped sharing so I can see your faces.
Thanks, Julie and Isla. Thank you very much. Very interesting talk, isn't it? And also very insightful. So I'm just checking with the attendees to see if there are any questions. Do pop in the chat or unmute yourself. And you have the mic to ask the question directly. So Julie and Isla, may I just ask a question? With the SMORPH TPN, for example, in gauche, for the longest TPN patients, for example, the chronic GVHD or long-term GVHD problems, at what point do you prescribe it specifically or compared to the short-term TPN?
It's used pretty much as our standard. We have one or two all-in-one bags where we use intralipid. So we have some scenarios where we have to use intralipid, or sometimes there have been supply issues where there's been shortages in provision. But it will be used as routine and standard because we know it's, you try and be proactive with liver protection rather than reactive. So yeah,
so majority of the time in BMT you would describe that, whereas in a AML mucositis patient for medium term you may not.
Yeah, and it's not that we have to specifically. So we've got a range of standard bags for GOSH, and then we have our bespoke. Obviously, our standard bags are more stable, and it's safer to use them. And a few of those standard bags are with intralipid only. So it might be where appropriate, we'll always try and use the SMORPH containing bags. But what you might find is actually in terms of calorie and volume provision, maybe an intralipid containing bag is better for that patient. And then you might say, well, it's only, it's an acute period, so it's totally fine to use it. So it's more if the other indications for those bags are more appropriate, but then we'll use those.
And then another note is to share with people is that even though patients are on TPN, for some patients, they still take some oral to maintain their oral functions in managing their care in cancer pathway, isn't it? So we have some patients who still nibbles on the orals, unless they are on chronic GVHD where they're strictly nil by mouth. Yeah, it's just to share with my nursing colleagues in the call. So the other thing is we all know a TPN is vesicant. So a good central line or, a good source of access is very important. And also for daily monitoring of a child on TPN, do you have any advice? I know in nursing, we would do biochemistry, bloods, to monitor it. Is there anything? Yeah.
Yeah, so I guess again, this is where collaboration and discussion with your NDT, and especially it will be patient specific. So generally when we are kind of building up TPN, especially if there is a risk of things like refeeding and things like that, that is when we would look at kind of daily urea electrolytes, CRP and things like that. When the child is on, and yeah, again, daily weights might be something that isn't necessarily from our perspective, but again, it's just to kind of be mindful of the shifts and kind of fluid and things like that. But yeah, trust by trust, it probably depends. But yeah, we know a child is also on PN for, an extended period of time. We also like to run through full nutrition panel screenings as well. And again, if there's kind of any risks or any signs of kind of any deficiency, it is always good to kind of test your prior to initiation, and then kind of later on when you have been established on PN. So yeah, initially daily, and then yeah, it kind of goes to roughly like every couple of days weekly. And, yeah.
But it's worth remembering that PN, because I think sometimes people think PN is like a cure-all. It doesn't have all the micronutrients and trace elements in it. We have to add those in. So they're not routinely added in. Some of our standard bags have them in, but that's why we tend to, once our child's been on PN for 3 weeks, we'll test for nutritional bloods and then make sure we're supplementing. So don't assume if they've been on PN and they've got all their micronutrient needs met. And you'll often, for those who work in our trust, will have us messaging saying, please, can you do these nutritional bloods? Because we want to make sure we're not missing out. And as we know, I mean, I'm sure dietitians talk about this way too much. Zinc is obviously micronutrient that's really, or trace metal that's really useful in terms of wound healing, recovery, and also linear growth. So that's a great example of, if we're missing that, we're going to be delaying their recovery and their overall nutritional well-being. So it is key to remember that these things need to be considered.
Yeah. So from nursing point of view, in the front line of care, weight is something that you monitor. Also the BM, daily BM, just to check that everything is ticking correctly. And for those children who are sensitive to fluids, for example, in VOD cases, weight might need to be taken twice a day. And also the general care of the CVL line, where you're giving TPN, because that's your main source, isn't it, of access.
And I think it's also worth remembering how it's been prescribed, because
Yes.
I don't know how this varies from trust to trust, but our scripts come up with a prescription rate of aqueous and lipid, but depending on the fluid restrictions or targets, or depending if we're weaning PN, the doctors might change that rate at ward level. So the script might say one thing and the ward level might say another thing. So obviously you're the ones hanging it up. So make sure that, I'm sure you do, but that it's been confirmed with the medical team what rate it is. I don't know. Again, trusts may vary, but the doctors should be prescribing the rate on your electronic record system. But I think just checking those things can be useful.
Yeah, and you guys probably all do this as well, but also just very clear documentation of what amount of volume of PN you are giving, because there are some instances where, children kind of need medications last minute, where doctors adjust the rates, and then we're kind of, massively under, the originally prescribed TPN volume. So if you are noticing that you are kind of delivering less than what is, prescribed on the sheet, then do let your medical team and us know, because again, that is where something we can all collaborate on and make sure that they are still getting effective nutrition alongside what they medically need.
And I would say I find, sorry, I'm not just chatting, but I would say I also find, depending on the lines that they have, and I'm not brilliant with the names, but if you've got single lumen, or if you're short on line space with your other meds, just let us know, and if we've got room to concentrate the bag further, or increase the rate and reduce the running time of the PN, then we'll try and make it work. Don't stress about oh god, we can't fit these things in. We'd much rather adjust as practical at ward level to make it work for you and the patient. So just shout, really.
Yeah, so key message is collaboration with all the MDT.
Isn't that the way, Mary?
Yes. So, and the other thing is for the enteral feeding. So there's the enteral feeding as in nasogastric tube, there's the gastrostomy, and there's the NJ tube.
Yes.
NJ tube, which are in GOSH is less frequent than NG or gastrostomy tube. Any further advice for NJ feeding?
So
you wouldn't, yeah.
Sorry. So typically, so if we can feed into the stomach, that is generally kind of the first, point of call. We do sometimes progress to, feeding in the small intestine when we are finding that children are just not tolerating the volumes that, we would probably assume. Obviously with jejunal feeding as well, we just need to consider as well that can only did continuously as well. So, practically is it going to be an option? But we do often see that, especially in like children maybe where the location of the tumor is just pushing down, they do tolerate it better when it's just get a bit further down. I've often also had children that, respiratory wise, there's that risk of things like aspiration. And, when we are increasing their, especially if they are on highly emetogenic protocols as well, they are vomiting. So again, we can help try and minimize that by feeding lower. But again, sometimes it doesn't always help. And again, we can also add in the jejunal extensions to gastrostomies as well. So again, if you think that that is something that a patient would benefit from, if they are a candidate for a gastrostomy, also getting that, talk into works, because you can always, some of the doctors up here always say that they prefer to insert it into not, because it's obviously a pain if you do need it to go for a second procedure, and then you can still feed via the gastric port as well. Yeah.
I think it also depends on trust. I know for us, I think we're quite lucky in oncology, because I think the indication for NJs is not as common in our area. But what we have found is we'll try everything enterally, and when things really aren't working, then we start to wonder if there's a mechanical issue, and we tend to then refer to gastro. They'll do all their checks and whatever. But if there's a mechanical issue, and like you said, not only because you could say, aspiration isn't a risk if you're NG feeding, but if your child's vomiting, then there's a risk of aspirating on the vomit. And I think that's where post-pyloric feeding is then helpful. So I agree with you, Mary. It doesn't happen very often, but we've had some absolutely, where gut motility and function's really been impaired, or aspiration's a big worry alongside the vomiting. And in those scenarios, as Ida said, you'll NJ feed. And although you can't do continuous, you can gently build the rate up to make it like short periods of continuous feeding to make it practical for home. But yeah.
Yeah, interesting. So the one thing that we in GOSH do is also we pair up TPN, parenteral nutrition, with continuous NCA, so it's continuous analgesia for severe pain control. So that's one thing that, for some seriously ill children that we would do, and I don't know if other centers do that, because we've proven that it is compatible, and that's one thing we can do. Just to share that across all the attendees here. So we're going to come to an end of this session. If there are any more questions, do raise your hands, unmute yourself and ask. I don't see any more in the chat. So I'm going to share the feedback link. If you could provide feedback, what we do is SIOP Europe will analyze the feedback and will share it with the presenters. And will also inform us of our future project. You could either scan the code, or I'll put the link if it's easier for you on the chat, and you can click it and do that. But I wish to thank Ayla and Julie. It's been very interesting, and you've also presented, I think Gosh presented in one other session in the series. So thank you very much. It's always very interesting. We are trying to encourage collaboration between dietitians and nurses, and it's all towards the care of the cancer patient. So any dietitians out there who want to join the SIOP Europe Nursing Working Group in our projects, do tap into our meetings. It's monthly, and we meet on a Thursday. There is a series of meetings set up. The next project we are going to do is looking at guidance for nurses and guidance for children, patients, and family, and to see whether we can come up with a leaflet card, information card. So we welcome the input from all dietitians. If there are any joining us on this call, apart from Ayla and Julie, to work with us on this project. So thank you very much for your participation. The feedback is there. Scan the code and provide the feedback. And meanwhile, if you're a nurse, do join our nursing working group. The General Assembly is in November. There's a little QR code there if you want to join the nursing group. It's quite straightforward. It's free to join the nursing working group. Just email Charamichi or fill up the form in the QR code. Thank you very much, everybody, for your
Thank
participation.
you.
Thank you.
Thanks
Thank
to the
you. Bye.
speakers. Thank you.